Good morning. We're going to start exactly on time this morning because the medical students have this room at 8:20. It is my real pleasure to introduce two of the stars of our division today. Dr. Kelly Branch is an associate professor here, trained after medical school at Jefferson at the University of Michigan and here at the University of Washington. He is the director of our cardiovascular clinical trials unit. And I don't have time to go into the details of Dr. Probstfeld's illustrious career. However, I will say he is a professor in cardiology here with over 240 publications to his name. It's my great pleasure to introduce both of them this morning for this really interesting talk that I know we're all looking forward to.
As I've already said, my mother would be very proud. Jeff and I are very happy today to be talking about something that we've been involved with now for the past few years, which has come to fruition, and that is specifically the COMPASS trial. And so we're going to be talking about the use of low-dose Rivaroxaban with or without aspirin in a relatively novel patient population for the use of NOACs in patients with stable cardiovascular disease, including peripheral or carotid artery disease. These are our disclosures. And just so you know, most of these data, are published in the New England Journal. There are two additional topics that we're going to be talking about in peripheral vascular disease and cardiovascular disease, coronary artery disease. Specifically, they're also going to be published in Lancet. They were supposed to be published this week, I'm told. Maybe next week, I'm not sure. But the sub-studies will be available in the Lancet. So just to start off, I'm going to be introducing, and then Professor Probstfeld will be talking about the results, and then I'll come back at the end for conclusions and some questions. But just so that everyone, to put everyone on the same page here, we know that cardiovascular disease is a huge burden. And if we look worldwide, which is more and more how we're looking, we see that it affects approximately 4% of the world's population. That is 300 million people. So if you took the entire world population, it would be the entire population of the United States that would have cardiovascular disease. Aspirin is the single most widely used medication, but it only really provides about a 19% relative risk reduction in major adverse cardiac events over the long term. So still much work to do. Warfarin, a kind of a medication that we love as well as hate, when used with or without aspirin, was actually shown to be more effective to reduce major adverse cardiac events than aspirin. But why wasn't warfarin used? Well, the bleeding rates were unacceptable, and warfarin's warfarin. Too many interactions. Finally, with the advent of the non-vitamin K or anticoagulants or NOACs, Rivaroxaban was shown to be safer in many ways than warfarin, and was shown to reduce mortality in patients with acute coronary syndrome. So if we look at some of the proven secondary prevention strategies, as noted here, you can see that even though we're making huge strides, and these are have been incremental, so these are building on one another, looking at lipid lowering for 1 millimole per liter or 39 milligrams per deciliter, which is how we think about it, you can see that the MACE, or major adverse cardiac events, reduces approximately 21%. For every 10 millimeters of mercury blood pressure lowering approximately 20%. The use of ACE inhibitors in these stable patients, 22%, and then of course aspirin, and you can see some of the other changes. So these are all really been wonderful, and overall we've seen a substantial improvement in cardiovascular outcomes, especially within the first world countries, if you will. Although this is becoming really a burgeoning problem now in the so-called second or third world countries, where McDonald's and Kentucky Fried Chicken now have substantial penetrance. If you're looking at the possible alternatives to aspirin, these are some, and I think the audience here is familiar with many of these. If you're using clopidogrel rather than aspirin, we saw a reduction in major adverse cardiac events. If you use clopidogrel plus aspirin, some reduction, although at the cost of a substantial increase in bleeding from 25 to 62%, depending on how bleeding was measured. And we will spend a little bit of time talking about how bleeding is measured in clinical trials later. If we look more recently at the Pegasus trial using ticagrelor, either 90 or 60 milligrams, we saw also a reduction in major adverse cardiac events, but we saw a substantial increase, 170% increase or 132% increase in major bleeds, including intracranial hemorrhage. And so, although people have been very interested in the outcomes, we know that because we are using medications that will decrease blood clotting, that means it is at the expense of increased bleeding. And so, in order to try to start this idea, we need to go back many years, 20, 30 years. And this is one of the studies, and I'm going to show some meta-analytic data, but one of the studies looking at secondary prevention with warfarin, comparing warfarin to aspirin. This is the WARIS trial, and looking at warfarin, aspirin, or both after myocardial infarction. And if you look at patients that were randomized to warfarin with an INR of 2.8 to 4.2 versus aspirin, or the combination, a little more modest warfarin dose, and it followed up for a mean of 4 years, you can see that as far as event-free survival goes, warfarin plus aspirin actually had slightly better than warfarin, but statistically, both were statistically superior to aspirin. What was the flip side? Not surprisingly, because again, it's warfarin. This is a medication that prevents blood clotting. Major bleeding was a huge issue. And as we added warfarin plus aspirin, we saw a substantial increase in bleeding to 0.62% per year. If we looked at the meta-analytic data, this is from Sonia Anand, published in JACC, looking at, again, at cardiovascular, major adverse cardiac events, cardiovascular death, myocardial infarction, and stroke, looking at oral anticoagulants, mostly warfarin in these trials, versus control. We saw a substantial reduction of about 42%, really quite statistically significant, and the WARIS data were included within this meta-analysis. If you looked at oral anticoagulants versus aspirin, again, a substantial 21% reduction in major adverse cardiac events. And if you looked at oral anticoagulants plus aspirin versus aspirin, a more modest but still a 12% risk reduction. So it seems as though using an antithrombotic, specifically an oral anticoagulant, as compared to aspirin, did have some benefits. But what were the benefits if we really looked at important, very important outcomes, i.e. all-cause mortality, which would bring in not only the cardiovascular benefits, but also weigh the potential fatal bleeding issues. And we saw that when we did that, looking at these various studies, we saw no substantial improvement in mortality, but did reduce stroke by 25%, and then that seemed to carry the day as far as the major adverse cardiac events. So what is a possible, and I say possible, this is something that they really conjecture, but what could be the reason why we have a little bit more benefit? It could be that it's more effective, it could be that it's more effective at blocking, but it also could be that thrombin is actually a bad player. If we look at the atherosclerosis, looking at some of the players within the thrombotic system, these actually can stimulate atherosclerosis, and I'll march us through this very briefly. If we look at platelets that are activated, so they've gone from smooth and now are quite rough, once they become activated, then they will associate themselves with monocytes and become an aggregate. And once that happens, that is actually pro-inflammatory in and of itself. I'm not going to go into the details, but just this is more of a gestalt. But through multiple pathways, we have increase in inflammation, which has been tied to, specifically in animals, increase in atherosclerosis. In addition, the platelet monocyte aggregate also increases leukocyte recruitment through a series of receptors as well as cofactors, and then by binding to P-selectin has monocyte to macrophage differentiation. We then associate with oxidized LDL, increasing foam cells, and really the initial step towards atherosclerosis. Now, it's not only platelets, but also activated platelets work with thrombin, and it is a two-way street in that as activated platelets affect thrombin, thrombin affects activated platelets. But obviously, thrombin also goes through other pathways, and that is the more classic antithrombotic pathway through factor 10A and also tissue factor and 7A. And once we looked at that through really a series of different mechanisms, through complement, through PAR, specifically PAR 1 and PAR 4, we also showed an increase in inflammation. And then thrombin in of itself, just the presence of thrombin, has a host of inflammatory responses and changes, endothelial changes, as well as angiogenesis, oxidative stress, and finally smooth muscle proliferation, all of this leading to what we would consider classic atherosclerosis. So thrombin seems to be a bad actor. And if we use warfarin or aspirin, we can block these in various ways, either at a little higher level for aspirin, a more substantial level for warfarin, but this may be the reason why we're seeing some benefit. If we looked at the anticoagulants in atrial fibrillation, and as we know that atrial fibrillation patients tend to have cardiovascular disease, atherosclerosis, there is an association. Looking at the meta-analytic data in over 71,000 patients, not too surprisingly, stroke and embolism goes down. These patients are highly predisposed. If you look at major bleeding compared to with the non-vitamin K anticoagulants versus warfarin, major bleeding was reduced. Total mortality was reduced, not too surprisingly. But interestingly, not much change within myocardial infarction. We would expect it in these patients with a high prevalence of not only atrial fibrillation but atherosclerosis that we would have seen a change, suggesting that there may be some equivalence. Hence comes the ATLAS ACS2 TIMI 51 study. This study was over 15,000 patients that used a very low dose novel anticoagulant, in this case Rivaroxaban, 2.5 milligrams BID, so this is approximately 1/4 the average dose, and then gave it to people right after acute coronary syndrome. It was at the physician's discretion whether or not you added a thienopyridine, but because we're used to dual antiplatelet therapy after acute coronary syndrome and stenting, most patients, 93%, were actually randomized to that, so they had triple therapy. And the triple therapy would have been either aspirin and or thienopyridine, randomized to placebo, Rivaroxaban 2.5 milligrams, or Rivaroxaban 5 milligrams, and this was an event-driven study. Looking at the endpoints, and this was published in New England Journal. These are Kaplan-Meier curves looking at cardiovascular death, MI, and stroke. These are major adverse cardiac events we're going to be seeing again and again. There was a substantial 16% risk reduction with the addition of Rivaroxaban 2.5 or 5 milligrams, with a number needed to treat of approximately 56 in order to prevent one of these outcomes. If we further broke this apart into cardiovascular death, MI, stroke, cardiovascular death, or all-cause death, all of these were statistically significant. You can see the hazard ratios there, but I think it's pretty clear that we saw substantial improvement, and all of these curves are at the 2.5 milligram dose, which interestingly actually showed more benefit than the 5 milligram dose, and that's not only adverse cardiac events, but also bleeding. This was tempered a little bit by an increase in bleeding because of the triple therapy, and because of some trial problems, mostly actually trial problems, not necessarily the data, but there was also confusion about if 2.5 is good, why wasn't 5 better? This was actually not approved in the United States, but was approved in Europe and other places. Based on these data, we decided to enter into the COMPASS trial, which is the cardiovascular outcomes for people using anticoagulation strategies, which the acronym isn't quite as bad as some of the other ones where they just randomly take, letters from the middle. So way to go, John Eichelboom. But suffice to say that the objectives were to determine in stable cardiovascular disease, different from the ATLAS patients with your post-acute coronary syndrome, to randomize to Rivaroxaban 2.5 milligrams BID with aspirin, or Rivarox 5 milligrams only, no aspirin, and compare cardiovascular death, stroke, or myocardial infarction, major adverse cardiac events we've seen in many of the slides previous, and all of this to really what we consider our typical therapy now, which was aspirin on top of guideline medical therapy. We also had, this is a 3x2 factorial, so, which we'll show the 3 arms, and we're really only going to be talking about the Rivaroxaban versus aspirin arm. There is an ongoing arm which had randomized people that were not on proton pump inhibitors to pantoprazole versus placebo to see whether or not the use of pantoprazole would decrease the most common cause of bleeding, which comes from the GI tract. That is ongoing and will be available sometime, probably in summer 2018. I'm going to go briefly over the exclusion criteria, and I've simplified this because, like many trials, it's a little bit difficult to get through. But these were relatively sick patients. So if we looked at the inclusion criteria, they had to have coronary or peripheral vascular disease. The coronary disease was history of significant cardiovascular events, such as a limb amputation, not a toe amputation, limb amputation, prior myocardial infarction within the last 20 years. In addition, they had to have they could have a history of revascularization, either stenting in more than one vessel, if they had bypass surgery in more than one vessel. So trying to get to the patients with not just one coronary lesion, but multiple coronary lesions. They could have revascularization and substantial residual coronary disease. If patients had symptoms, either angina or claudication, and then had a greater than 50% stenosis supplying the ischemic vascular bed, then they were able to be enrolled. The exception is if they had PAD symptoms and asymptomatic greater than 50% carotid stenosis, they could also be entered. And then in patients less than 65, we had a little augmentation. They had to either have 2 or greater, either smoker, diabetes, EGFR less than 60, but greater than 15, heart failure, or non-lacunar stroke. The exclusion criteria are fairly obvious in some ways. High bleeding risk, including liver disease and coagulopathy. Those patients would not be appropriate patients clinically nor in the trial. Patients that had stroke less than 1 month, so high risk of hemorrhagic conversion, or lacunar strokes, which also have a high risk. Patients with significant CHF, class 3 or class 4, EGFR less than 15, because these are renally excluded. Needing full anticoagulation or non-aspirin antiplatelets, so those already on thienopyridines could not, or full anticoagulation such as warfarin could not be included. Poor prognosis, and CYP3A4 or PGP inhibitors, strong inhibitors that is. So this is the simplified slide. The idea was that we would take all of our patients, we'd have a 1-month run-in period where they were given aspirin. We would give them aspirin plus placebo. And the idea is that this was an adherence problem. Some people have said that we tried to exclude the bleeding issue, the bleeders, if you will. That was not the case. This was an adherence issue. That is, if they could take these medications, then these patients could actually enter into the study. This is an adherence issue, not an exclusion. And most of the exclusions were because of non-adherence or not wanting to be in the trial. Again, you can see here we were randomized to either Rivaroxaban 2.5 plus aspirin, Rivaroxaban 5 milligrams alone, or aspirin 100 milligrams. And the expected follow-up was 3 to 4 years, event-driven trial to 2,200 patients with a primary outcome event. Primary outcomes, again, we've seen this again and again: cardiovascular death, stroke, myocardial infarction. A couple of secondary outcomes with CHD death, adding in only ischemic stroke rather than all stroke, myocardial infarction, or acute limb ischemia, because these were peripheral vascular disease patients. Secondary only change from CHD death to cardiovascular death, and finally all-cause mortality. And these were powered in a way where, in order to ensure that we weren't just tiddlywinking these, that there was a more rigorous p-value which had to be met. Primary safety outcome, obviously if we're giving Rivaroxaban, there's a concern about safety. And then we had looked at a couple of different bleeding, but decided on the most conservative bleeding strategy that was out there, something called a modified ISTH score. And essentially it was ISTH bleeding, which is a score. We've seen Gusto, you've seen TIMI, there are some other ones, but this one also, in order to be conservative, we said anytime the bleeding, anytime someone complained of bleeding and came to healthcare, that is, if they came specifically for an urgent care to their primary care physician, that was considered a bleeding event. If they came to the ED and were released, that was considered a bleeding event. They didn't have to have transfusion. They didn't have to have anything done. If they sought medical care, we consider that a major bleeding issue. Finally, we had calculated a net clinical benefit, which was major adverse cardiac events, and then minus any fatal bleeding or symptomatic bleeding into a critical organ. With that balance, we tried to figure out whether or not the benefits outweighed the risks of bleeding, and this was really a simple subtraction, non-weighted, and we will see the results in a second. And now I'd like to introduce Dr. Probsfeld, who will go through the results of the COMPASS trial.
Thanks, Kelly. So let me just start by telling you a little bit about the PHRI collaboration. The PHRI collaboration involves 80 countries now. And I keep telling my longtime colleague Salim that this is by far his best work. When you sit down in a steering committee meeting of these people, it's like a small meeting of the United Nations. Wonderful collaborations, excellent colleagues in all countries. So this particular trial involved 33 countries, and you can see the performance of each one of the major players in terms of the recruitment on the slide. Not surprisingly, I believe Argentina led the way again, and the Netherlands was second, believe it or not. The interesting thing is that you almost can just put out a flash fax and say who would like to participate in a trial, and about a half an hour later you know who the participants can be. On February the 6th of this year, the Data and Safety Monitoring Board met, and they decided, because of the fact that the Z-score for the Rivaroxaban aspirin combination had a score of 4.59, which was equivalent to a p-value of 0.401, that the trial should be stopped because of benefit. Now, the next line is a mouthful. The closeout happened between March and June. That means that all 27,000 patients were seen in whatever clinic they had and were closed out. There was a formal closeout of every patient. The interesting thing is we happen to have the largest clinic in the entire operation in this country, had over 300 participants, and they closed out all of their patients between those two dates. The Rivaroxaban arm alone, the 5 milligram arm, really did not have a Z-score that required stopping. The mean follow-up was 23 months. You may recall from Kelly's description of the design that it could have been something of the order of 3 to 4 years. Now, this participant flow diagram is one may be difficult to read and is probably too complicated to digest from the back of the room. So let me just say, we screened over 28,000 patients. 1,400 of those were post-CABG. We had a specific subset that we wanted to look at from that. 27,000 of those patients were randomized. The randomization to each of the three arms is almost spot on identical. You can see that the number of people who dropped out of each of the arms is almost spot on identical. The baseline characteristics, so let me help you read this slide because you can't digest all three columns. Just simply take my word for it that the distribution of the factors is equal across all arms. Focus on the left-hand column. The age was an average of 68, 22% were female, blood pressure relatively well controlled. You can see the cholesterol. 91% had coronary artery disease, 27% had peripheral arterial disease, and 38%, obviously because of the allowance of additional risk factors without coronary disease, the number of people with diabetes was increased from what we would ordinarily expect, about 20 to 25%. Same deal here. The randomization takes care of the distribution very nicely. Just focus on the left-hand column, 62% Caucasian, extremely small number of African Americans, and this is not surprising since, you know, most of the patients come from either North America or Europe. Asian, 16%. Others 21, and obviously we do a little disrespect here. This should, you know, this is Hispanic and others. And you can see what the distribution is for the various regions of the country. You can see that the largest proportion of these patients comes from Western Europe and also from South America. Again, baseline characteristics. This is the first trial that I've been in where we had over 90% of the patients on a statin. Again, same drill. Left-hand column, 90% on a lipid-lowering agent, 71% either on ACE or ARB. You can see the next three items, beta blocker obviously for either treatment of coronary disease or control of blood pressure, and you can see at the beginning 36% were on a PPI. So I think it can be said that the participants in this trial were on very good levels of secondary control of coronary disease. Permanent discontinuation, I just urge you to look at the bottom line. We had predicted by the end of the trial that roughly 15% of the participants would be off whatever their intervention assignment was. And you can see that not only was our prediction fairly good, it was good in all of the arms of the trial. Okay, so the primary outcome. You can see here there were 379 primary outcomes in the R plus A arm, 496 in the aspirin arm. The interesting thing here is you may remember that we were targeting 2,200 events, and 500 plus 450 plus 380 is not close to 2,200 events. So we were able to stop considerably short of the targeted number of events. Rivaroxaban plus aspirin had a 24% reduction in the primary event rate. A couple of comments here quickly. We started out with 19,500 as a targeted estimated sample size. That was increased to 21,000 a few months into the trial because of concerns about low event rate. And then after that, again, the sample size was raised to 27,000 because of concerns about low event rate. Well, obviously, the trial really was really, I think one can say, overpowered rather than underpowered. So this is just the Kaplan-Meier plot, and you can see the plots of the three intervention arms here with a 24% reduction in the Rivaroxaban plus aspirin arm versus the aspirin arm. I'm not a big fan of the number needed to treat statistic, a discussion for another time, but you can see the NNT here is 77. Secondary outcomes, well, had several secondary outcomes. I want to focus particularly on the bottom line, mortality. And it's said in the paper that this ended up not being statistically significant. I had a long discussion with my friend Dave Demetz, who was the chief statistician in this trial. And he said, I've even argued before the FDA that you don't do statistical correction for mortality. What's the reason for correction? You're trying to avoid the introduction of bias. Well, how do you have bias when you're basically counting bodies? A little hard. So at any rate, David has argued, even before the FDA, that the mortality outcomes should not be corrected for multiplicity. If you don't, obviously a 0.01 p-value gives you a very nice reduction in mortality. Here are the primary components, and you can see that CVD death, by what I've just discussed, is nicely reduced. Stroke is enormously reduced, and MI has not been reduced yet. This is quite consistent with previous trial outcomes, and we are now engaged in a 3-year follow-up with patients remitted to their previous primary caregivers to be treated with whatever they want. The one proviso is that until the drug is approved by the FDA, the drug is going to be given out at the centers so that patients can continue on Rivaroxaban. This is a totally unreadable slide, and I give you that. The only thing you need to look at is where all the dots are compared to the line of unity, and you can see they're all to the left, and this is what it shows in terms of the primary outcome. You have some with an extremely small estimate with very wide confidence intervals, but the short story here is there isn't any subgroup that suggests that there is a difference in the outcome. We don't have a slide of the bleeding from all of the trial, but you can see this is a representation of the bleeding outcomes that occurred in the PAD subgroup, over 7,000 patients in this. And you can see they're all to the right, so it doesn't really make any difference what subgroup you want to look at. The increase in bleeding was there. Major bleeding, approximately 290 events in the R plus A group versus 170 in the aspirin group, highly statistically significant. But here is the very interesting and what we think is a very important part. The number of fatal bleeds is obviously only slightly increased in the R plus A arm, not significant, and the non-fatal intracerebral bleeds is only very slightly increased, and as far as we're concerned, this is extremely good news. The net clinical benefit. Now let me just pause to say that there are a number of ways to calculate the net clinical benefit. The way that it was done in this trial was the subtraction of the deleterious events in bleeding, namely bleeding, from the overall benefit, and that's the way we got the net clinical benefit here, which shows that you have a hazard ratio of about 0.8, which is a 20% reduction in risk. So even though there is some bleeding, the net clinical benefit is quite positive. So Rivaroxaban 2.5 milligrams twice daily plus aspirin reduces CVD death, stroke, and MI. It increases the ITHS modified bleeding without a significant increase in fatal, intracranial, or critical organ bleeding, and provides a net clinical benefit. There's no significant benefit of the Rivaroxaban alone arm. So how about COMPASS in context? COMPASS is in the last column now, the other 4 columns you saw earlier, and it doesn't really make any difference whether you look at MACE, death, stroke, MI, bleeding, interpret carefully. COMPASS with Rivaroxaban plus aspirin appears to be very nicely superior to the other trials that have been done in the past. Proven effective secondary prevention therapies. This is try to put this in context. You can see that certainly COMPASS with the Rivaroxaban aspirin arm adds very nicely to the estimates of treatment benefit from the other secondary prevention measures that have been used, including lipid lowering, blood pressure, ACE, and aspirin by itself. Now this is purposely put this way because this is my colleague's invention. He said he wanted to particularly raise the issue that it's very hard to stack the particular benefits of one intervention on top of another in any of these trials. So Kelly very nicely put together this slide, which attempts to show you what the benefit is in MACE, mortality, stroke, and MI, particularly in the COMPASS trial. And I think this very nicely depicts that. The COMPASS PAD trial, we had several sub-studies in this trial. The PAD was one. We're not really going to discuss MIND, which my colleague is very fundamentally involved in. And there were several other sub-studies that were done in this trial. And there's going to be really powerful data that comes out of those. The PAD trial, as did you mention there are two papers coming in Lancet? Yep. Yeah, they're about to come, and the PAD paper is one of those. And in many estimates from the collaborators, the PAD paper is probably the most powerful of all. So I really urge you to look at the Lancet to see that. Short story: PAD patients have widespread atherosclerosis and increased risk of CVD and limb adverse outcomes. There are few, I think you can almost change that to no therapies, which have clearly reduced major adverse events in the limbs. The primary goal was to test whether Rivaroxaban with or without aspirin reduces MACE and MALE, that is major adverse limb events, compared to aspirin in PAD patients. Eligibility: you had to have peripheral arterial revascularization or limb or foot amputation for arterial vascular disease, or intermittent claudication. You can see the criteria for an ABI, or significant peripheral arterial stenosis as diagnosed by arteriogram. Previous carotid revascularization, asymptomatic, carotid artery stenosis greater than 50%, and CAD plus low ABI was also possible. The primary outcome, again, for the whole trial was MACE. We were also interested in looking at that in this subgroup, but the primary focus of this subgroup was to look at major adverse limb events, that is severe limb ischemia leading to an intervention, that is angioplasty, bypass surgery, amputation, or thrombolysis, and or major amputation above of the forefoot due to vascular cause. So the number of patients actually was over 7,000. You can see those who were symptomatic, those who had carotid disease, and the last row has the number of patients that had CAD plus a low ABI. 7,470 patients altogether. Again, look at just the left-hand column because all of the other two columns are basically the same. 68 years of age, current smoker 27%, former smoker 46%, so 73% were either current or former smokers. Diabetes 44%, hypertension 79%, prior CAD or stroke 69%, and you can see they were on both lipid lowering and ACE or ARB. So here are the primary outcomes. You can see on the MACE, almost an identical reduction in risk with a hazard ratio of 0.72, maybe even a little bit better. MI was reduced numerically, but really not statistically significant. Stroke was reduced also, but again, numerically, but not statistically significant. Really no surprise, and the same for CVD death. The limb outcomes on MALE, that is major adverse limb ischemic events, You had 30 versus 56, which is nicely reduced, even statistically, and major amputations. You probably should ignore this particular set of data because the numbers are very low. Goes in the right direction, okay, but yeah, I think the numbers are very small. And here is the, pardon me, here's the display using the Kaplan-Meier plots. The net clinical benefit, again, described as we had before, and nicely clinically beneficial. Now, regardless of whether you want to look at the overall PAD, symptomatic PAD, PAD lower extremity, or carotid artery disease, you basically have a very similar point estimate of the benefit. So, the COMPASS PAD conclusions: Rivaroxaban 2.5 milligrams BID plus aspirin is significantly superior to aspirin alone in reducing MACE, male or major amputation, significant reduction in the stroke, huge reduction as in the overall trial, increased major bleeding, but no significant increase in fatal or critical organ bleeding. And my colleague will take us home.
So thanks, Jeff. So in the last couple of minutes, we will go over a few things. I think we're going to, because of time, because we have to let the medical students in so that they can do their learning and we can promote education. We'll skip a few slides at the end. But we were fortunate to have really, you know, I don't know, minor deity. Would that be an adequate description for Dr. Braunwald, who will actually be here at the University of Washington? But he was kind enough to offer up his comments and thoughts at an editorial that accompanied the New England Journal article. And specifically, we took out one quote. He said, "This trial represents an important step forward in thrombocardiology and is likely to change practice guidelines. But it's not the end of clinical investigation in this, but is it the end of clinical investigation in this area? Probably not," which is very good news to clinical trialists like myself. So some of the proposed future research, which we very much agree with, because as most trials do, they answer some question. In this case, we show benefit. All trials will generally give you some type of answer to a question. And like all trials, they just lead to more questions. And in this case, some of the proposed research would be: the next trial should be a head-to-head comparison between aspirin and a second antiplatelet drug, dual antiplatelet therapy, versus a very low dose of a factor Xa inhibitor. In this case, we've used Rivaroxaban 2.5. Substituting a PY12 inhibitor or thrombin receptor antagonist for aspirin versus the very low dose of the factor Xa inhibitor with aspirin. And then a subgroup of patients with stable ischemic heart disease, ACS, or those with CHF with various combinations of these agents. What it tells us is that Professor Probsfield can never retire. So just to take you through the very end, I'm going to show these very briefly. This was a study that's now in press, but through our colleague who is the other country co-coordinator in the United States, Dr. Deepak Bhatt, who needs no introduction. But we're able to take the REACH registry, which was 68,000 patients internationally, and then to try to apply these data to see whether or not what we found in COMPASS would be applicable to a large international cohort. And the REACH it's most globally inclusive, so rather than just the United States or North America and Europe, was really worldwide, broad spectrum of diseases, and really was a real world population. And we did this because primary caregivers get these data and they say, this doesn't apply to my patients. REACH, however, would apply to my patients in a real-world setting, and so we went back and said, how many of these patients would fit the COMPASS criteria? Of the 68,000, nearly 17,000 met eligibility with a high bleeding risk, but they were excluded through the high bleeding risk, required oral antithrombin therapy or DAPT. and some other exclusions. So I'm just going to go to the summary slide, which is here. And then if you looked at the COMPASS eligible patients within REACH, that's in purple, versus the COMPASS participants, you can see that overall the patients that were in the REACH registry were actually higher risk than COMPASS. So these were not sub-selected uber high risk patients that are not applicable to clinical practice. As a matter of fact, this is typically what we see, that patients in clinical trials seem to do a little bit better. This may have been in part the Rivaroxaban arm, in part just being in a clinical trial, the so-called Hawthorne effect. But suffice to say that these patients seem to represent real world, even though there are statistical differences, these patients in COMPASS seem to be lower risk than those patients in real world practice, suggesting that this could be applied. So in conclusion, Rivaroxaban 2.5 milligrams BAD plus aspirin 100 milligrams a day decreases major adverse cardiac events by 24%. And this is across the spectrum of peripheral vascular disease, coronary artery disease, as well as subgroups. Using the conservative bleeding measures that we've talked about earlier, these are increased by approximately 70%. However, the most important bleeds that would really balance this out as far as mortality, including life-threatening bleeds, critical organ bleeding, no statistical difference, leading to a net clinical benefit in favor of low-dose Rivaroxaban plus aspirin. If we looked at the subgroups of coronary artery disease and PAD, I just looked, the Lancet still has not published this, but we're hoping soon, that the subgroups show similar benefit, and in peripheral vascular and peripheral arterial disease, there is a significant benefit in major adverse limb events. This is hugely important because it's been almost decades since we've seen a real substantial improvement in PAD patients. Huge. And so the vascular community is very, very excited about the possibility of applying this drug to their patients. Further evaluation of covert stroke and coronary artery bypass grafting, the sub-studies, one of which I had presented at research rounds with the COMPASS MIND study, those are pending at this point, but will be out within the next year or so. And then, of course, the challenges that are being developed. Which patients should we really target? It's hard to get to the inclusion criteria. Is there an easier way to figure out who benefits most? What about the cost analysis? Huge problem for our patients. How expensive is this drug going to be, and then how does that impact our patients? Can they afford it? This is going to be part of a late-breaking presentation at the American Heart Association, for which we are contributing now. So more data are pending. And finally, the comparison to other treatments as outlined by Dr. Braunwald. We talked about those before. So much work to do, but at least we've had a definitive trial with a definitive answer, and now we have definitive marching orders to try to get additional information. Finally, I'd like to acknowledge the people that are really doing the work not only worldwide but also in the National Leaders Office in COMPASS, Janice Johnson, Jill Anderson, Greg Mueller, and our co-leader Deepak Bhatt at Harvard, the U.S. investigators, the project office at PHRI, biopharmaceuticals, which underwrote this. However, they really had no input as far as the conduct of the trial, and then of course the trial leadership and the steering committee. And with that, thank you very much. Jeff and I are very happy to have presented today, and we will take questions for approximately 3 more minutes until the medical students kick us out, because they have more power than we do. Thank you very much. Questions?
Yeah, how do you explain the MI findings? So, I mean, the first thought is that there are fewer MIs than cardiovascular deaths, but there are actually more. And whereas the cardiovascular death finding was significant, the MI was not. It wasn't really even close. So, I mean, but you think that was the mechanism, right? So how do you explain that?
The only thing I can say is it's consistent across the trials that have been done so far. And what the mechanism is for it not turning up, what I'm desperately hoping in the 3-year follow-up that we have now, that somehow that will flip over. But, I mean, it's certainly going in the right direction. Consistency with other trials beyond that, David, I don't have a good answer, and it's a very important point.
Yeah, what I would say is that I actually took the statistics and then back calculated how long we would have to go in order to actually see the magical p-value, and we would have had to go for 8 more months if the curves stay exactly the same and the hazard ratio stayed exactly the same. If we went for 8 more months, we'd get the magical p-value, but not substantial.
Having said that, from
be careful, I'm just saying.
From the time that the trial was stopped, they've looked at the data again, and if anything, those are narrowing instead of getting broader. So it's, this is the wiliness of clinical trial data.
Yep.
So hopefully the 3-year follow-up will do it.
How much of this is just treating occult AFib?
None of the patients in the trial, well, we have no evidence that any of the patients in the trial had AFib.
Yep.
But we know that probably there is.
A cold AFib.
There could be occult
Yep.
AFib, but we don't have any evidence.
Yep.
I mean, we have ECGs at intervals,
Yep.
and that's as best we can do.
Yep.
That might explain the production and throat and maybe even.
And actually, we did not see this, and I'll tell you why we think that is probably not the case. Number one, it's undertreated, right? Because it's only 2.5 milligrams. The second thing is that we looked at incident atrial fibrillation, which should at least have some idea about whether or not you're going to move this. So we saw about 300 atrial fibrillation through the average 23-month follow-up, and that was actually distributed through the trial. New England Journal had a huge discussion about this. All 7 reviewers thought that this was very important. So many discussions about it. But the fact is that we saw no overt atrial fibrillation signal, and that is clinically relevant. Could it be? We can't tell. We can't tell. So that has been suggested as another study to do at some point.
But the evidence is against it. Let's be clear about that.
Yeah, the evidence is against it. Yep.
One more, any more? Thank you so much.
Okay.